Morning, everybody in Pune, and good evening or whatever time it is where you are. If you were intending to join the Pune International COVID Knowledge Exchange session for the Operation Breathe, you came to the right place. We are here today to talk about ambulatory care, antivirals, and antibody, which is a new thing in COVID-19. We have a wonderful team today, Dr. Bharat Purandre and Dr. Shiva Iyer from Bharati Vidyapeeth, and Dr. Robert Gottlieb from Baylor University in Dallas, Texas. And Dr. Priscilla Joshi will be moderating this session. And Dr. Joshi is also from Bharati Vidyapeeth. Just to remind you, this is a knowledge exchange of practitioners in the front lines of managing COVID. It's not a webinar. It's not nobody's talking at you. This is brief, didactic, and we hope to have case-based discussions. Anyone can bring a case or a scenario to discuss. This only works when we all teach and we all learn. And our goal here is to connect with physicians in the frontline in Pune area. We have wonderful faculty from Bharati Vidyapeeth, alumni of the Armed Forces Medical College, and many people from all over the world who are dealing with COVID-19. We are blessed to have excellent collaborations with JAPIGO, which is an NGO involved in capacity building in COVID. And this platform is brought to you from ECHO India. I want to tell you ahead of time that the theme next week is ventilating the COVID patient, nuances, and I'll request Dr. Iyer later in the conversation to talk a little bit about it. We have sessions planned after that on long COVID and pediatric COVID. With that, I'll stop and hand over to Dr. Priscilla Joshi. Dr. Joshi.
Thanks a lot, Krish. And welcome everybody to this session, Knowledge Exchange on COVID. We'll be talking about ambulatory care, antivirals, and antibody therapy in COVID. We have a panel of experts. Let me briefly introduce them to you. Dr. Robert Gottlieb is board certified by the American Board of Internal Medicine. Cardiovascular and adult heart disease. For the last 1.5 years, however, Dr. Gottlieb has been involved in a number of therapeutic trials in COVID-19, and he works at the Baylor Scott White Health System in Dallas, Texas. Dr. Bharat Purandre is an infectious diseases specialist who is faculty at the Bharati Vidyapeeth Medical College and also works as a consultant at Dinanath Mangeshkar Hospital. He's done his graduation and post-graduation from BJ Medical College, including a gold medal from BJ for medicine. He subsequently did his fellowship at Hinduja Hospital in Mumbai in 2009 and has been working as a consultant in infectious diseases for the last 11 years in Pune. Dr. Shiva Iyer, you are all familiar with. He's been there on a couple of sessions earlier with us. He's professor and head of critical care at Bharati Vidyapeeth Medical College. He's also adjunct assistant professor of Prince of Wales Hospital, Hong Kong. And he has a number of other affiliations. He's been past president of the ISCCM. His area of expertise is ethics, end-of-life care, communication, education, mechanical ventilation, nutrition. And he's been awarded the Commonwealth Scholarship for pursuing MSc in palliative medicine from the Cardiff University. So as you can see, we indeed have a panel of experts here with us. So let's go on to see what they have to share with us. I would request Dr. Gottlieb Roberto to please tell us about his experience. I'll just start sharing screen.
So thank you for that kind introduction, and it's a pleasure being able to share in this information exchange. There's certainly a lot of difference and commonality in different countries, and so I appreciate the opportunity
Can you
to
see,
hear the
is my screen
hear and
showing
learn about
the Baylor University screen?
Yes.
Yes.
Okay, great. Okay, sorry. Go ahead.
So I'd like to, because this is a time where neutralizing monoclonal antibodies are beginning to reach India, I wanted to share the experience behind some of the data, so that if you're in the position that you're able to offer this for some of your patients, that you can apply it with good stewardship and to good efficacy as well. It's a privilege being able to share this with you. Next slide. Let's see if so we're all in this together. It is true that one person can change the world if they are the carrier of a zoonosis. But otherwise, we go much further by doing things together. And there's never been a greater lesson than that in the last year, where things have gone at breakneck speed, and it's really required doing it together. Next slide. One of the problems with COVID-19 is that we have one name for multiple different disease states. And there's some patients that aren't even symptomatic. Do they have COVID-19 or are they just SARS-CoV-2 carriers transiently? We have the same name for mild or moderate COVID-19, as well as severe and critical. Every patient, at the beginning, you don't know what their trajectory is. It's my firm belief that no one dies of COVID-19 in the first few days. The first few days, in my opinion, is a virally coupled disease. And the second portion is a virally uncoupled disease. And the way I would look at it is, if you have a burglar in your house, you can capture the burglar when they're setting off the alarm, when they're entering. If, however, you don't want to capture a burglar, let them in, give them a week lead time, leave the door open, come back from out of town, see that your place has been ransacked, and now go to try to find them. And that's really with severe to critical COVID-19. That's really what we're doing. We've tried antivirals. They do work in hospitalized patients with on low flow or room air or early portions of high flow with remdesivir. But after that, everything else is really steroids for hypoxemia. Question is, how do we get it upstream while the virus is earlier, while it's still virally coupled? And what I'm going to share with you is, we actually know that some of the therapies that do work early, the very same therapies don't work late. And I'll share this with you. Next slide. Again, this is really just the spectrum that you're all familiar with. And this is just a visual representation of what we'd like to be working on. Is on the far left, we would much rather be working even before asymptomatic or pre-symptomatic, because we'd rather prevent the disease with vaccines. And every country has different panoply of vaccines available. And really, we can reach many more patients with the vaccines than we ever can with treatment. But once we're unfortunate enough to reach treatment stages, we'd really like to be in that first phase. We know that we've learned, surprisingly, that masks work incredibly well for decreasing transmission. Masks are really a pharmacotherapy. But if someone does get the disease, especially when we have a sparse resource or a scarce resource, how do we steward this? How do we help as many patients? How do we maximize the efficacy and minimize the number needed to treat to prevent a hospitalization or prevent a death? And when hospital beds are in short supply, preventing a need for hospitalization can actually save many more lives than just the one you're treating. And if you can prevent death from your therapy by providing your therapy earlier, that's even better. We'll really focus on this mild to moderate and early therapy. Next slide. This is universal, despite the politics associated with it. I do think we should avoid saying the Indian variant, because quite frankly, by calling it the Indian variant, it makes it sound like it's just in India. It's already global. We actually know from Ebola that we shouldn't be naming viruses after locales. And we saw the politicalization of weaponizing the name of an origin of a virus from the origin of a country which is really at odds with the fact that this is really a virus that attacks humanity as long as you have at least one lung. This really has shown that we have more similarities and differences across political spectrum, across everything. Next slide. Early in any epidemic or pandemic, you can start with certain types of therapies that are humoral therapies that are off the shelf or more easily off the shelf. So you could recover patients that then are a source of polyclonal convalescent serum. Cardiologist, and I'd rather prescribe someone aspirin than prescribe them willow bark. Willow bark does have aspirin in it. I can control the lot-to-lot variation or minimize lot-to-lot, prescribing well-defined, well-characterized aspirin. The same thing here is really the concept of antibodies. What you're doing is you're sorting and then sequence those plasma cells and refine to the most avid, most neutralizing monoclonal antibodies, and basically an advanced form of convalescent plasma, neutralizing monoclonal antibodies, either alone or in combination. In general, we know that from TB to any bacteria to any virus, it's better usually to target at more than one spot to minimize escape. If you want to get escape from TB, provide serial monotherapy. If you want to treat TB and prevent it from recurring and minimize resistance, treat with multivalent therapy, treat with quadrivalent therapy. Same thing as I think what you're going to see with neutralizing monoclonals, although there is a new one that came out just last week that is a monotherapy. We're not going to go into that too much today, but I just want to let you know that there are some monotherapies still out here. There's no resource limitation from a blood donor to make neutralizing monoclonals. It's just a resource limitation of manufacturing capacity. Once you create it, you can characterize it. You could even eventually think about a day where you could have a way to find out what is circulating in one region and target your monoclonals to that. Next slide. No one ever asks the question, if someone has influenza, you know, gosh, I'm just going to wait until you're sicker to figure out if you really need Tamiflu, also Tamivir. Or I'm going to wait until you're, to treat you with an alternative, whether it's amantadine or the new Xofluza. Yet with this pandemic, we taught everyone, stay at home, don't infect anybody. And I've had patients come to me say, well, I'm not sick enough to need a neutralizing monoclonal antibody. Well, if someone has risk factors, you don't want to wait until they manifest progression, because if you wait until they manifest progression, you're already losing the window of efficacy, and you're actually increasing the number needed to treat until it eventually actually becomes futile to treat that patient, and you'd rather treat someone further upstream. So if there is a big push for stewardship, I've seen that in my own experience, but if someone is eligible for the therapy, is early in the disease process and has risk factors, those are the people you want to treat, even if they're doing well, as long as it's early in their disease course. Because you wouldn't hold Tamiflu, you want to treat it outpatient. You want to treat SARS-CoV-2 outpatient before it progresses through the stages of COVID-19. Next slide. I'm not going to have time to go over everything, and this is supposed to be an information exchange, but suffice it to say that we now have at least 3 different manufacturers and an onslaught of additional ones that are coming down the pike, releasing phase 3 data, showing what you need to know. Ultimately, you want to know is, you don't want to know as much, does the monoclonal decrease your viral load? You want to know, does it treat my patient? Does it help my patient? And so as we move from phase 2 to phase 3 data, we actually looked at, can we decrease hospitalizations and death? And that is what Lilly has shown. That's what Regeneron has shown. and that's what GSK has shown. They're different antibodies, but the theory is all the same, and they all corroborate each other. This isn't a case of pharma working at odds with each other. This is pharma reinforcing that this is a concept. You can, as long as you choose good neutralizing monoclonal antibodies, it's likely to work. Of course, you need to get the safety and efficacy data. I do want to point out that if you look at the literature for these, they do change endpoints and they do change inclusion criteria as they go on to learn in an incremental and additive way. Blaze 1 has always, this is the Lilly trial, has always requested inclusion within 3 days of the first positive test. The reason was, you ask about how long someone's had symptoms, there's subjectivity and people will change their answer to what you want to know. If you do it from the first positive test, it's objective. Regeneron actually said, you need to have a test positive within the first 3 days, but it has to be 7 days from the first symptoms, and you could retest to recreate the 3-day testing window. They then changed it to say 3 days from the first positive test. We'll go into this and we'll show you what that significance of that 7 days is. And then VIR 7831 is monotherapy. It's actually covers both SARS-CoV-1 and SARS-CoV-2, which is a nice feat. And actually, who knows, maybe we'll mitigate other SARS viruses from this pandemic. The bottom portion is really important. We've shown if multiple different therapies in active 3, this is inpatient study of some of the same neutralizing monoclonal antibodies, it doesn't work if you wait until they're inpatient. Regeneron did the same with an inpatient study. If you wait till they're hospitalized, people get hospitalized in the 2nd week after seeing the virus when they're already about to have a humoral response develop. And that lead time that you give them by passive immunity with neutralizing monoclonal antibodies, it doesn't give them any additive benefit because within a few days they're going to have their own antibodies, but the disease course is already virally uncoupled. In the next few slides, I'll just show you that data. Next slide. So this is the Blaze 1 study, phase 2. This is a study that I published in JAMA back in January of this year with my colleagues from this trial and my partners at Lilly. For full disclaimer, I do not have any investment in Lilly or any of these companies. The blue line, though, there's 2 messages to really be shown on the left side. First, masks, I'm not going to talk about the therapy for a second. I'm going to say that masks work, and here's why masks work. On the left side of the screen is where your nasopharyngeal viral titers are actually the highest in the early symptomatic or maybe even pre-symptomatic phase. Once diagnosed, the levels actually tend to naturally clear. There is a hypothesis that some patients have persistent viral load, but the loads don't go up. They actually go down regardless. They might not go down as much as you might like them, but with so this is important. Masks work because don't be so afraid of the patient in front of you that you know has it. Be more afraid of the person working next to you that doesn't have a mask on, that doesn't know they have it yet. So masks work, and these pharmaceutical trials actually inform this by showing that the viral titers are highest early. It also is a message of hope because the viral levels do come down, and this also informs us a little bit about duration of quarantine. I personally think 10 days is a little short. I'd rather 14 days, but it gives you a concept that by day 14, you're already 3 to 4 logs down, or by day 11, you're already 3 to 4 log down from your starting titer. Now, on top of it, if you use a combination in this blue, this is bamlanivimab and etesevimab, a combination from Lilly, you actually can further decrease the natural clearance and augment that clearance and get to a lower viral load that is statistically significant. And on the right, you see in this blue that combination therapy is more effective and actually already has an effect by day 3, increases out by day 7, and persists out to day 11. Clearly, if you were to wanted to decrease viral load the most, you would choose this combination therapy. But what you want to know is more about how do you treat a patient. So the next slide. This is the phase 3 data that I have access to. There's visually, descriptively the similar results from Regeneron. Regeneron is the one that you now have access to in India. I think that is a perfectly fine and probably a better therapy right now, given the circulating variants in India at the moment. We asked with 1,000 patients on the left, 1,035 to be exact, and on the right, this was halfway through the next 1,000. We asked at 2 different dosing levels, could we decrease in a randomized placebo-controlled trial, could we decrease hospitalization for COVID and all-cause death? And the answer is yes. In fact, on the left, we had a 70% risk reduction. In the end, we actually had 12 deaths in the placebo arm. 8 were from COVID. We had 0 deaths in the active arm, and the overall risk reduction was 70%. We used a lower dose because if we use a lower dose, the question is, can we treat more patients? And the answer was yes, because we then used a lower dose, and the primary endpoint was retained, if not even maybe even a little bit better, at 87%. This was halfway through that portion of the trial. And again, all the deaths accrued on the placebo. We will not do a placebo-controlled trial again for neutralizing monoclonal for high-risk patients because this works. It does make additional trials very challenging. Again, if you remember only one thing from this talk or this sharing exercise, I want you to remember this because you're going to ask, does this actually help my patient? Does it just treat the virus but not help my patient? The answer is yes, this helps treat your patient if you use it early. Remember the slide. This is early within the first 3 days of the first positive test. The emergency use authorization goes out a little bit longer. Okay, next slide. This is what happens if you wait. Now this is monotherapy with only bamlanivimab alone, but this is at an exceedingly high dose. We used actually 7,000 milligrams, 7 grams of a neutralizing monoclonal here. And these disposition curves in time to recovery and time to hospital discharge are effectively superimposed. I believe, and I might be wrong, I believe it's virally uncoupled or starting to become virally uncoupled by the time you're hospitalized. It probably is slightly virally coupled early on because that's why remdesivir still works in that window. Again, this is to show you don't want to wait for your patient to get sick enough. You don't want to steward and hold on to the drug waiting for a patient that's sick enough, because if you're waiting for them to become sick, you're losing the window. Next slide. I think I only have 1 or 2 more slides. This is just to show the hypothesis of the persistent higher viral load at day 7 might predict who's at higher risk. And also this shows efficacy. On the left in gray, you have placebo. 20% of patients had persistent high viral load, defined as greater than log 5.27. With combination therapy, it was about 2.5%. Next slide. This is why you're not getting bamlanivimab and etesevimab together in India. Etesevimab might work well with something else, but we haven't studied that yet. Bamlanivimab does have about 2 orders of magnitude fold shift, and that's why the decision has been made to favor, in this case for these variants, to favor the Regeneron product. And you may even see the GSK product come forth at some point. We're also looking at other antibodies that are that cover the variants additionally, and I have current trials ongoing for that. Next slide. This is one more way to share with you the importance of treating early. In that panel A, what you have is placebo versus 2 different dosing levels of the Regeneron CoV-2 product. And what you see is that the higher dose and the lower dose of the Regeneron CoV-2 both work comparably well, so we can treat more patients by using a lower dose. Now, remember, Regeneron said you had to have symptoms less than 7 days. Well, if you know that, some patients will say, I've only had symptoms 7 days, or people can't recognize how long they've had symptoms. So 2 ways to assess that is, in panel B, these are patients that were already on the left in panel B are patients that were seronegative. You had a good effect still. Both Regeneron cocktail doses decreased the viral load. On panel B on the right, however, if the patients were already seropositive, there is no difference. This makes sense. If you already have your own humoral immunity that's developed, you're not going to gain by transplanting passive immunity with a humoral therapy. On the bottom is another way of saying the same thing. If you'll remember, the viral loads are actually highest at the beginning. So if you have a lower viral load, that really implies that you've actually probably had the virus for longer. And in fact, there's no difference in the curves. But as you start having a higher viral load, suggesting it's earlier, you see more and more of an impact. So the sweet spot is getting as early as possible into the disease course before a patient gets sick enough. Ask not whether your patient's too well for the therapy. Ask if they're actually too late to get a benefit from the therapy. You'll save more people that way. Next slide. Now, this is the United States criteria. This is different from the criteria in India. So I don't want you to dwell too much on this. In the US, we do it within 10 days of symptom onset, with the earlier being the better. You have to not require hospitalization for COVID-19. Doesn't mean you couldn't deliver it in the hospital if you were, let's say you got into a car accident, you don't need to be in the hospital for COVID, but then while you're in the hospital, you got sick and you're early in, you could still give it. But if you're sick and hospitalized for COVID-19, don't waste the product on that. Give it to someone that's gonna get the benefit. I've already shown you that it's not effective in the hospital. You only have to have one mild or moderate symptom. I would suggest that you constrain it to patients that have a lab diagnostic test of either a rapid antigen or a PCR. Now, I don't think you necessarily need to test for serology. If you do have serology that says that they've already seen it, I probably would not treat that patient. I'd probably treat somebody else. The risk factors for progression, these are the ones that we originally studied. We've relaxed them in the US since this, and actually India actually has a little bit of a different criteria. So in India, instead of age 65 or greater, it's age 60. You have to only have one of these. Diabetes mellitus, type 1 or type 2. In India, you add liver disease, chronic kidney disease of any stage, immunosuppressive disease or immunosuppressive medications. That could be a patient who's had a history of an organ transplant or has inflammatory bowel disease or has rheumatoid arthritis. Obesity in the US was initially defined for the purpose of this as 34.5. We've relaxed it. In India, it just says obesity. It doesn't define it. Age, we initially had some age criteria for cardiovascular disease, hypertension, or lung disease. In the US, we've since removed those criteria. In India, you're very fortunate to have a situation that does align with the United States. It also trusts you as internal medicine providers, general practitioners, clinicians at bedside. If you believe your patient's at risk for progression from some evidence basis, you're able to treat your patient. So the purpose is to not excessively steward, but to at least make sure that you're getting to a number needed to treat that is as good of a balance as possible without withholding the therapy, because it's just as important to treat a young patient with risk factors as an older patient. It's the patient in front of you that is going to get the benefit from your therapy. With that, I'll turn it over. I think that was my last slide.
Thank you, Dr. Gottlieb. And I'm sure all of you have a lot of questions. I would request Dr. Gottlieb to answer as many as he can in the chat, and we will take the questions on again at the end of the session. So we go on to a couple of case scenarios. And we would request the audience to participate in these case scenarios. There will be a polling which will be done. Our first patient is a 65-year-old man under treatment for myasthenia gravis who presented with cough, anosmia, loose stools, fever of 100 degrees Fahrenheit, body ache. Recently, his son had tested positive for COVID-19. What will you advise? Ambulatory care or admission? Can I have the polling on, please? So the first question is, what will you advise? Is it ambulatory care or admission? Second question is, what tests would you advise? Would you advise antibodies?
This only works if everybody votes. I don't see any votes yet.
Please vote.
Are you able to see the vote, the polling?
Would it be worthwhile perhaps going back to the question one more time?
Okay, we gotten the answers. Okay, so we go on to the answers later. Everybody, I think 75%, 83%, now it's gone to 80.
We'll have to wait a little bit. Only a few
So
people
we'll
are
wait for
voting.
all the answers to come in. So we have only 26 who have voted. Request all of you to vote.
It's a participatory exercise and gets everybody thinking.
And it's all anonymous, so it doesn't matter. In the bar below, there is something which says polling. You have to access that and poll. Next to mute, stop video, security, participants, you have a polling. So please click on that and poll. So should we go ahead,
Yeah.
Krish? We have 42 out of 91 who have polled.
Yeah, I think
And we have 67% who have voted in favor of ambulatory care, 88% in favor of RT-PCR, and antibodies, no, in 76%. Can we get on the next questions, please, Akash? We'll discuss them after we finish the tests.
Ma'am, you can just scroll down. There are some answers below.
Okay, sorry, I didn't realize that. 4 is inflammatory markers. Again, yes, in 86%. Tests, LFT, RFT, HbA1c, yes, in 88%. HRCT, I'm glad, no in 64%. So that means that our episode and the segment we did on HRCT has helped. Drug treatment, B complex C, zinc, 81%, ivermectin, doxycycline, no, 2-deoxyglucose, no, and what drug treatment, methylene blue, no. So I think we'll, Shiva, would you like to come on and discuss this aspect? Dr. Iyer?
To
discuss
Priscilla?
this? Yeah.
Yeah. So I think pretty much people have, for the HRCT, they have answered absolutely correctly. Now, doing the inflammatory markers at this very early stage may not be of much benefit. And of course, the RT-PCR, but it would help to establish a baseline if you have the inflammatory markers. And of course, the RT-PCR would be better than the RAT because of its greater sensitivity and specificity. This we had discussed last time. Now, regarding ambulatory care, I think in this case, one would opt for ambulatory care because the patient is having mild COVID-19. If we look at the ICMR WHO classification, so his oxygen levels are probably normal and he does not have um, a higher respiratory rate. So one can opt for ambulatory care. And with regard to the treatment, we have Dr. Bharat with us, who will probably comment on this.
Bharat, could I request you to comment on the treatment?
Yes, so basically
I'll share your slides if you like now.
yeah, it's absolutely okay, madam, if you share the slides. Regarding this case, I would say that this patient is at high risk of progression, and one should consider antibody cocktail if we have got a proven RT-PCR in this patient. Of course, antibody cocktail has its own issues of cost, availability. We have to check whether he actually fits into the EUA. I think he fits into the EUA with the preliminary information that they have got. We don't know whether the patient is on any immunosuppressants, but I believe for myasthenia gravis they may be giving steroids to him. It's possible. So he might actually fit into the EUA for the antibody cocktail. But undoubtedly, at this point of time, this patient is for ambulatory care. As and when the symptoms develop or worsen, the patient should be advised to get admitted. So there are three parts of the ambulatory care. This patient has to be given symptomatic therapy for whatever symptoms he has got. Number two, he should be educated about what are the symptoms of a severe disease, what mandate a clinical examination, personal visit to the doctor, and what mandates an admission. And number three, one has to develop a mechanism so that that patient can follow up with the healthcare provider or the hospital, so that if at all he requires admission, the process can be smooth and without wasting much time. But if we have to give him antibody cocktail, we have to be really quick. As Dr. Roberto has already told us, it has to be within first 7 days. He's already third or fourth day into the symptoms. So he quickly needs an RT-PCR to prove his diagnosis and then go ahead with the treatment. Now, this slide which we have displayed indicates the life cycle of the causative virus SARS-CoV-2. So as you can see that the virus enters into the cellular membrane, it uncoats itself, it releases its genetic material, that is the RNA, then it gets translates into various proteins, then repacking of the virus and budding out. So this life cycle gives us various potential targets for therapy. So you can see that various targets have been mentioned in the on the right hand side at various points of life cycle. So not all of these medications are right now in clinical practice. Some of them are still investigational. Some of them we are actually using, for example, favipiravir and remdesivir, and some of them are just available like monoclonal antibodies, and some of them are still not available to us. And this is an ongoing process. So we are going to get possibly more and more products targeting various life cycle events of the virus. Can we go to next slide, please? So the antiviral agents are so broad that one cannot actually combine them in one slide, because there are various types and they can be literally from antibiotics, antivirals to antibodies. I mean, it's a here also there is a mixture of various products which can be used as antiviral agents. So Dr. Robert has already given a detailed overview about monoclonal antibodies. So that already now the audience knows. We are using remdesivir. Some people are also using convalescent plasma. Mind you, it's also an antiviral agent. We were using hydroxychloroquine or chloroquine products some time back. Now we have discontinued its use. Most of us have discontinued using it. favipiravir and ivermectin. There are many more, but these are the ones which are commonly in use. So shortly we'll go and see what are the current place of these agents in COVID-19. Can we go to next slide, please? So what is the current place of remdesivir? So most of us know that it's a nucleotide analog and it inhibits a viral enzyme called as RDRP. In this trial, which is called as ACCT1, it was shown that it can be used in hospitalized patients who are having severe COVID-19, and it has a reduced time to recovery. So it reduces the time to symptomatic recovery in the treated group. But in the WHO trial, which was called a Solidarity trial, it was shown not to improve any patient outcome as regards the length of hospitalization, admission into the ICU, need of mechanical ventilation, and 28-day mortality. So WHO has recently removed remdesivir as a part of recommendation in the treatment, but other guidelines from NIH, from Infectious Disease Society of America, and also our own guidelines from AIMS, they still continue recommending remdesivir for a select class of patients. I would say for all hospitalized patients, it may not be indicated, but people who have got higher CT value or higher CT scoring, CT severity scoring, and those who need supplemental oxygen, one should consider giving this drug. But it's again ongoing matter of debate. Last few months, people were asking, why are you not giving remdesivir to my relative? Now people have started asking, why are you giving remdesivir to my relative when WHO has removed it from guidelines? So that is the big clinical dilemma here. But still we use it in patients who require supplemental oxygen. Now, this has also received a EUA, which is emergency use authorization, along with baricitinib for patients who are requiring either oxygen or mechanical ventilation. That was the recent development. Many people are aware of this development. But baricitinib, which is an immunomodulator, should not be used alone. It has to be used along with remdesivir. There are certain gray areas about use of remdesivir. If the disease has already crossed 12 days of duration, should we use it? Nobody knows the real answer. It's a doubtful area. If patient's creatinine clearance is less than 30, the manufacturer says that you should not use this drug, but we end up using this drug for many people who have got chronic kidney disease or even acute kidney injury. And in the earlier part of this epidemic, the second wave, we found that some patients had received it early on, and after 10-15 days, they again became febrile and hypoxic, and again showed all features of severe COVID-19, even after receiving remdesivir in the early part of their illness, maybe 8, 10, 15 days down the line. So whether one should reuse it, that's again a different or a contentious issue. Next slide, please. So I'm just going to speak a few lines about convalescent plasma and hydroxychloroquine. Convalescent plasma is like a cocktail of passive antibodies, but they are not monoclonal, they are polyclonal. And Dr. Robert already made a mention of them, and he compared both of them side by side, convalescent plasma versus monoclonal antibodies. They have to be used early on within first 7 days of onset. Role is presently unclear because again WHO has discontinued its recommendation on use of convalescent plasma as one of the therapies for COVID-19. So currently it should be used only in the context of clinical trial. There are some centers in Pune city who believe in plasma and who continue giving it. And most other centers have already discontinued using convalescent plasma, particularly when we have got the monoclonal antibodies on board. Hydroxychloroquine has failed to show a clear clinical benefit in the treatment of COVID-19. There is a potential for toxicity in the form of QT prolongation, ECG changes, and arrhythmias. And in June 2020, whatever emergency use authorization it had received in between was revoked by the FDA, and they stopped using it, and even we have stopped using it. About favipiravir, favipiravir is again an RDRP inhibitor. It has to be used early on for a mild disease. It is not recommended for people who have got features of severe disease. The earliest trials of favipiravir had shown modest benefits in terms of time to recovery and reduction in the severity of clinical symptoms. But further data was largely lacking. And here I would say that people should use it if at all their institute has given a guideline to use it. We are going by our own institutional guideline. Our institute where I am working does not recommend favipiravir. About ivermectin, it's basically an antiparasitic drug, but it has been shown to show an apparent in vitro activity against SARS-CoV-2, and its use also has been recommended only in context of clinical trial for either ambulatory patients or patients who are only mildly sick. But data favoring use of ivermectin are not very robust, and they are from very small trials. And largely, again, I would say if the institute recommends ivermectin, one should try and give it. And our AIMS guidelines are recommending use of ivermectin in very mild disease or patients who are ambulatory. So I think we have come to our last slide now. Madam, can you display the last slide? Yeah, and so other agents who are being evaluated are anti-HCV drugs, which are sofosbuvir, daclatasvir, one antidepressant called fluvoxamine, which is a selective serotonin reuptake inhibitor, and other agents such as famotidine and zinc. But large clinical information about use of these agents is not available. Only small trials of hundreds of patients are available, and we still need to look at the data very closely before starting to recommend these agents. Dr. Iyer, do you want to take the discussion forward?
Shiva?
So, madam, you can start displaying the next case that Dr. Iyer had prepared.
Okay, so our next case is a 78. Thank you, Bharat, for giving us all the information on the various drugs available. Our next case is a 78-year-old man with uncontrolled diabetes. His last HbA1c was 11%. He has cough, fever, shortness of breath, extreme weakness for the last 7 days. The RAT is positive. After walking for 6 minutes, his SpO2 is 91%, pulse 100 per minute, and respiratory rate is 26 per minute. What will you advise? So we get back to polling. Akash, could you start the polling, please? Request all of you to join in. We've got some more information. I think we've exchanged some
Could you go
information.
back to the, should you go back to the case so people can look at the case while they're
Okay,
filling?
I'll go back to the case. 78-year-old man, uncontrolled diabetes with an HbA1c of 11. Symptomatic for 7 days. RAT is positive.
Is everybody able to see the poll?
Yeah, the fourth question, Krish, is this patient, which would you use? Steroids? It doesn't say yes or no.
1 second. Can I go to the next?
It's a multiple choice.
Will you use steroids or will you use baricitinib? A or B? That were the those were the options.
I just didn't see them there, so thank you.
Okay, sorry.
So I do think that there's another choice. There should be another choice for 4, and that is neither.
Yes, we should have probably done that.
I think we can have some interesting discussion on this one. Yeah, more people are voting this time.
Yeah,
This is great.
So that's what we thought, that we would discuss the first case and then put up the questions on case 2 and case 3.
Mhm.
about 60% have voted. Should we start
Yeah.
discussing the questions?
Yes.
Shiva, Roberto, and Bharat,
So,
would you take on
You know,
the
I think-
discussion, please?
yes, and it's interesting because I wonder if you might get a couple different answers from us. You know, the first question I would have is, how do you grade the degree of COVID-19 here? And the definitions of COVID-19, I think our definitions are a little bit inadequate, but at least are guided, they guide our trials. I personally believe that there's going to be something else of prognostic feature that we're going to be able to add in a few months, but I can't share it yet. It's not validated. But for the time being, I would make a cut point of your resting SpO2. And unlike other respiratory viruses where you might say 88 or 90% for admission, I generally recommend admission at 93%, you know, maybe sometimes 94, sometimes 92. The issue here is we are faced with an SpO2 of 91%, but it's after walking for 6 minutes. And I would suspect that the patient at rest would likely have an SpO2 north of 94% or higher. And so I would say this patient has radiographic infiltrates, probably has moderate COVID-19. You wouldn't be wrong to admit them to the hospital for remdesivir, but you also are in a situation where you could also treat them because they have the diabetes and they're not longer than 10 days. They're not as short in the disease process as you might like. They're still within the window for neutralizing monoclonals. I personally believe that not only do the neutralizing monoclonals have a survival benefit here in the ambulatory setting, in the inpatient setting, I do believe that remdesivir is still the standard of care, at least in the United States, for someone that is not worse than high flow nasal cannula. I have done additional analyses that I participated in that I do believe that there's a survival benefit for remdesivir. But getting back to the label, I would say that this patient has moderate COVID-19. And the question is, you are justified in treating this patient ambulatory with close monitoring. You're justified to treat them inpatient. But I would say that they're not sick enough to need oxygen and not sick enough to need immunomodulation right now, because we know that this is a patient, we have the data, they're not requiring oxygen supplementation, and there's no benefit and actually even a trend towards harm in this patient receiving steroids. Later on, it might be a different story. And I would say, given the net mortality benefit, I would probably favor treating this patient in the ambulatory setting to enable them to receive neutralizing monoclonals.
Thank you, Roberto. Bharat and Shiva, anything you'd like to add to this?
I believe this patient is already showing evidence of involvement of the lung because he becomes hypoxic on 6-minute walk test. So I believe he already has a progressed disease, and definitely I would like to admit this patient. I think it already surpassed the time point where you give monoclonal antibodies.
I would agree.
Because hypoxia on, I would not advise him monoclonal antibodies. I would advise him admission, see whether he progresses. And if he progresses, he becomes hypoxic more and more, he starts requiring oxygen. I would go for remdesivir as well as steroids. Baricitinib can also be given if at all steroids are contraindicated because of some reason. But there are hardly any such patients in whom we cannot give steroids except for a certain class of patients in which they are contraindicated. There we can give baricitinib. But this patient needs admission, and this patient is likely to become hypoxic with full-on oxygen in next 2 to 3 days. So I would definitely advise this patient admission.
Thanks, Bharat. Shiva, anything you'd like to add?
No, nothing to add. I agree with Bharat, especially I think he's outside the window for monoclonal antibodies. And I would agree for admission and giving remdesivir.
Okay, that's great. Should we
And
go
to-
on to the next case now? Thanks a lot.
To
Roberto has
clarify
something to
what,
say.
Yeah, tell me. Yes,
know,
Roberto.
if the patient had presented with a SpO2 of 91% at rest, I would agree with all of those assertions. In my experience, if a patient, rare would be the patient that has a, I would expect the imputed SpO2, I would expect to be greater than 94%. And that's the tenet for my recommendation. This does illustrate the art of medicine and interpreting concrete data according to context, and reasonable physicians can come to different conclusions faced with the same data.
Thank you. Thanks, Roberto. So should we move on to the next case? Our next case is a 49-year-old social worker and Anganwadi worker. These are the rural healthcare workers. She's admitted in the oxygen ward for last 5 days with severe COVID-19, requiring 12 LPM on the NRBM. She is still breathless. Pulse is 100 per minute. Respiratory rate is 28. She has fever, 100.4 degrees. Her SpO2 is 93%. The MET team has seen her and have advised her to be shifted to ICU for interference and further management. She has received remdesivir, dexamethasone, and enoxaparin, 40 milligram subcutaneously once a day. What are your further treatment options? So can we have the poll, please? So I'll show you the case scenario again. Every line here makes a difference to what you're advising. Every sentence you read. So we have more people answering this time, which is a good sign.
So definitely this lady is having a very severe COVID disease, and she is right now on optimal treatment, which is given at most of the usual settings. But if her hypoxia is worsening, if her fever is not going down, with reasonable duration of both dexamethasone and remdesivir, one has to think whether she now needs more immunomodulation, or in other words, whether she is a candidate of tocilizumab. What do you think, Dr. Iyer?
Yes, I agree that we need to use tocilizumab, I think, at the right time, and using at this stage would make the most sense, I think, because earlier than this, it is possible that you may experience the side effects. Later than this, you may not get the benefit. Though this has not been very clearly elucidated in the trials, and there are, if you look at it, there are 6 trials which have been done so far, and we discussed them a little bit last time. So the Covacta said that it was safe. The REMAP-CAP said that there may be a benefit to mortality in appropriately selected patients. Unfortunately, a Brazilian trial, Tosibras, was stopped early. We may have got more information from that trial. So I think, yes, we must evaluate for tocilizumab. So, Bharat, I'm interested in your response to see what you would do if tocilizumab were not available.
So
Yeah, so if
And
my
Roberto,
preference
of
will
course.
be to
Oh,
yeah,
Go ahead, Bharat.
I would quickly answer, then Dr. Gottlieb. Yeah, so my preference would be to tocilizumab. If tocilizumab is not available and patient's inflammatory parameters show that a lot of cytokine storm is possible in this patient, and I've carefully excluded infection out, even other options can be tried. So we had an access to itolizumab some time back. Now it's not available currently, but we have an access to other drugs such as tofacitinib and other drugs which we have mentioned in the next slide. So one can definitely look for immunomodulation with one of the other agents, but the data regarding those other immunomodulators is definitely less robust as compared to tocilizumab. And now with the pandemic coming down, I don't think there will be a big problem in accessing tocilizumab. So my preference will be to tocilizumab if there are no contraindications. Dr. Gottlieb, please.
So this is a case where the last year we've accumulated data, and I think the most surprising, at least for me personally, the most surprising portion was the power of steroids. And I think if you magically didn't have access to steroids, I think tocilizumab would be perfectly fine. I think in the presence of steroids, I think most other immunomodulation is no longer necessary, that steroids suffice as much as anything else. And so, for example, the ACT-4 trial really actually compared steroids to baricitinib head-to-head. And steroids it was stopped for futility because it was comparable. So it's not that baricitinib added to steroids gives you a better outcome. I think early on there was a lot of excitement about tocilizumab, but as you'll see with, although REMAP cap is a little different, once you see trials with high coverage with steroids, I think you'll see the tocilizumab impact wane to futility, and I think it will take a long time to decrease. Now, there is a subtlety here of, I think, some of the best clinical trial data that shows futility of tocilizumab for patients with high flow or worse hypoxemia. The trials themselves require time to enroll. And so there is a gap, and this is a patient that's acutely decompensating. There may still be a very narrow role for tocilizumab. I'm not saying it's not possible, but I don't think the average patient needs it in this situation. I do think that the inflammatory markers are useful, and there was one portion of the STEM of, would you continue steroids? And I absolutely would continue steroids. I've certainly seen people get 10 days of steroids, be doing really well, steroids stop, they rebound, their inflammatory markers rebound. I'm being asked to evaluate them for VV ECMO. I resume the steroids and they start improving. So this is exactly the patient to not withdraw steroids on, maybe actually provide them a longer taper when they get to a certain point. But I personally would not do anything else other than supportive care here and continuing the initiated therapies.
So I have two supplementaries on this, Roberto, and to Bharat. So one of the supplementaries is that, is there a place for colchicine? And I think Bharat has or may have used it a lot, from Roberto as well. And the second supplementary is about the dose of steroid. So is there anything to suggest that increasing the dose of steroid or switching to methylprednisolone, will that make any difference? And of course, colchicine. Bharat, and then maybe Roberto.
All right, those are quite interesting questions, and I don't think we can have a clear answer to them. As an institutional policy, what we do is all admitted patients of COVID-19, we are getting a CRP done. And if CRP is more than 75, we start most of these patients on colchicine upfront. I don't know whether this is right or wrong, but that's what we are doing. And we have found that it quickly brings down CRP. I mean, within 2 to 3 days, the CRP becomes just 3 or 4 from 112. I don't know whether it translates into clinical response, reduction in hospitalization, reduction in mortality, need of ventilation. But we have seen it bring CRP being brought down to in 1 or 2 digits from 3-digit value. So that is one observation that I have got. And we frequently call colchicine as poor man's tocilizumab because most of the Indian population may not be able to afford tocilizumab. But as Dr. Gottlieb had just pointed out some time back, that if you keep patient on remdesivir and dexamethasone and enoxaparin, there is a very, very small number of patients who are going to need further immunomodulation. Really a very small number. Most of them do show resolution of their hypoxia, resolution of their fevers, and resolution of their inflammatory parameters. So really a very small window or very small, narrow amount of patients will require further immunomodulation. And about the next question that you asked, Dr. Iyer, there are patients, a group of patients who progress while they are on this combination of steroids and remdesivir. So here the clinician starts thinking what else one can do. And sometimes we try to overdo the things and the patients land up in further trouble or more infection. So one has to take that call very decently when to use tocilizumab because it's a double-edged sword. The amount of prescription that we are giving of tocilizumab have reduced a lot after combination of remdesivir and dexa. We are using it, and maybe once or twice in a month we come across decision of tocilizumab. Dr. Gottlieb, your comments?
Steroid increase?
So in terms of
Yeah, sorry,
steroid,
I missed that point. Steroid. Let Dr. Gottlieb talk.
Yeah,
and I will
yeah.
talk.
Sure.
so in terms of steroids, I think one of the most important things here is to ensure that the steroids are being received and being absorbed. So if they were being given oral, I would switch to IV just to ensure that there's adequate delivery. In terms of dose, we tend to actually use a lot of times we use methylprednisolone just because it's on our formulary. We have dexamethasone as well. I don't see a particular difference between steroid. I do believe that following your CRP levels here could be of benefit. I think LDH is of low clinical utility here, but CRP as well as ferritin. And if you do look at the literature, I think it's important to recognize that there are 2 different forms of CRP that are just different by a decimal point, and to make sure that you're looking at whether you're dealing with milligrams per liter versus milligrams per deciliter, because that will you'll have to adapt your thinking to which scale you're referencing. It's just a difference of a decimal point. In terms of one of the options here, atolizumab, I personally have never used it because it's not authorized in the United States. And I believe the authorization in India came from a study of, I believe, 30 patients or so. It's exceptionally small. And I do believe that the multiple testing hypothesis needs to be accommodated because there's so many thousands of trials that by chance alone, especially with small numbers, the number 30 patients is really not enough to justify using. Now, in terms of colchicine, I'm completely neutral because I think it's a great question for a clinical trial. Over a year ago, in March of last year, I actually asked that question, what about colchicine? I believe there are ambulatory outpatient trials going on. I can see theoretical reasons why it would help or hurt. I have complete neutrality and equanimity and would welcome a randomized clinical trial in the inpatient setting. I only know of it occurring on the outpatient setting, but I might be mistaken.
Thanks,
Thank you.
Roberto. Thank you, Roberto.
Priscilla,
Should we go on to your slides?
yeah, just before that, this last question or comment from my side is about, people in desperation tend to give very high doses of methylprednisolone. Sometimes, 125 to 250 milligrams to 500 milligrams. I think that it does not help, and it may predispose to greater number of infections. So I don't really think that there is a place. Bharat, is there a quick comment from you on high dose methylprednisolone?
Yeah, sir, I would say that that recovery trial had used a dose of 6 milligram. The salt that we use in UK is different than what we use in India, and our equivalent dose is 8 milligrams. So if you are going to use steroids, it will be 4 milligram twice daily and for less than 10 days. Or if the patient gets discharged early in the hypoxic stage, you can stop it at 5, 6, 7, 8 days also. Not necessary to go ahead with whole 10 days of therapy. Equivalent dose of methylprednisolone will be 32 milligrams, but people end up using something like 60 or 80 milligrams also. But the equivalent dose is 32 milligrams of IV methylprednisolone. And again, people are giving in desperation pulses of methylprednisolone, which I think should be discouraged, because that will really push the sugar sky high. And we are also seeing a lot of mucormycosis. So one has to be very, very careful when we are using steroids, because the patient might just recover from one illness and land up into another illness.
I would echo that
Okay.
completely. In fact, the highest I've seen used in my institution is 1 milligram per kilogram of methylprednisolone or equivalent. Massive doses at some of the doses referenced, I would strictly avoid, and I would echo that completely. I think one of the biggest things that the pandemic has taught us is about ourselves as clinicians and physicians. And I found it very humbling in the face of equanimity and two different choices, the choice between acts of omission and acts of commission, both in the absence of data. Rather than have neutrality, I've seen a much larger percentage of physicians have a desire for active therapy, even if there's no database for it, and even if the risk of harm is equal to the risk of benefit. And that's been humbling. And I think it says something about ourselves of we yearn for something that will help our patients, but just yearning for that doesn't mean that it's correct to act. I think one of the most important things that patients need to know is that we care about them, that we care about their outcome, we care about them and their families, and administering medicines just to administer them with a potential toxicity profile really should be discouraged. And there's other ways to convey to your patient's family that we care about their outcome.
Thanks, Roberto.
Okay, so we're towards the end of the seminar now. Thank you, Bharat and Dr. Roberto. So I'm going to summarize on behalf of today's seminar. So, we've seen the natural course, and we saw Dr. Roberto Gottlieb tell us about how COVID-19 need not be thought of as a single disease. So its natural course is over several days, weeks, and maybe months. So we know that pathogenesis, viral entries through the respiratory tract, and it is essential that a successful virus evades the innate immunity. And the SARS-CoV-2 has shown itself to be a master in evading the innate immunity. Then, of course, there is viral multiplication, and the symptoms and the signs and the clinical features are a combination of the viral cytopathic effects and the stimulation of adaptive immunity. The outcome, if we think of, so I've put this as an example so that people get a sense of perspective. So if we take 1,000 patients, resolution is going to occur in 950 or more without hospitalization. Mild symptoms among these patients, there will be about 800 or so. Moderate symptoms will be around 150 or so. And if we think of the population that is likely to benefit from Regeneron COVID-2, and the benefit, please remember, in the trial has been shown to be the outcome of decreased hospitalization. It has not really been tested for morbidity or mortality, though Dr. Gottlieb showed us some data on file, which suggests that there may be an improvement in morbidity or mortality. Next, in hospitalized patients, you can see about 50 of the 1,000 will have moderate COVID-19, those requiring oxygen. Of these, about 10 out of 50 will develop severe COVID-19, going on to require high NRBM, HFNC, NIV, or invasive ventilation. And deaths may go from 3 to 8 per 50. So that would amount to a 30 to 80% mortality in the ICU. And this may be more or less depending on where you're situated and how overwhelmed you are. Then, of course, there is chronic disease, long COVID, which includes multi-system inflammatory syndrome, chronic respiratory failure, chronic fatigue, and psychological support. And of course, if they've been in the ICU for a long time, the post-ICU syndrome. One very encouraging feature for this, there has been more and more evidence, is that the recurrence is very, very low. I've put it as less than 1 per 1,000, but it may be even less than that. So can I have my next slide, please? Yeah. So this slide is something which Dr. Roboto has shown us. And you can see that the phases that I have put in are the incubation phase, the symptomatic phase, the early pulmonary phase, and the late pulmonary phase. So really, it is in phase 1 and phase 2, early phase 2, that the antibodies are going to be most effective. You can see at the bottom of the slide that the antibodies, the antibody to work best at this stage, the symptoms are generally mild and sometimes they may be moderate. So someone with moderate symptoms, yeah, and with risk factors or with higher age, then such people can be considered for antibodies. Okay, next slide. Yeah. So now this is a summary. So our treatment for COVID-19 and complications includes the antibody cocktail. Among the antivirals, remdesivir remains. Among the immunomodulators, it is clearly steroids, not high dose, the dose that is used in recovery, or its methylprednisolone equivalent, which is 32 milligrams, like Bharat pointed out. Then the use of anticoagulants, and this now is likely to change as more trials come in. Antifibrotics, there is no evidence. And then, of course, antibiotics, antifungals for secondary infection. Now, in the supportive care, and which is very important, is oxygen, which we tackled last time, respiratory support, which we are due to tackle in the next ECHO seminar, ECHO webinar. And we've tackled HFNC NIV last time, and we will tackle the nuances of invasive ventilation and see how we can provide better invasive ventilation to our patients. Then ICU hospital care. Now, this is something which we've been falling short of. So using a mnemonic like fast hugs BID, which is feeding, analgesia, sedation or analgesia for pain relief, thromboprophylaxis, ulcer prophylaxis, glucose control, skin, bowel bladder, infection control, and prevention of decubitus ulcer. So this is something which we need to focus on, improve our care. And then, of course, there is a large area of psychological support and helping people who may not recover and their families. So this is my last slide. And thank you so much, everybody, for a patient hearing. Over to Dr. Priscilla Joshi and Dr. Lakshmanan. Sorry. So this is an important slide, and I put this, especially to outline the ethical principles that underlie the treatment choices that we make. So when we think of it from the point of view of cost effectiveness, it is the utilitarian principle which says to each to maximize the number of quality adjusted life years. And you can very clearly see that here vaccination will score over everything else. The second principle is egalitarianism, to each an equal opportunity. And I think the availability of the antibody cocktail is to make this opportunity available to everybody in India, but not many people will be able to exercise this opportunity because it's too expensive. Then, of course, there's prioritarianism and the rule of rescue, which we use in the ICU. And one can again see, why ICU care is not subsidized in India. That's the last slide, Priscilla. Sorry. Yeah. Okay. So now this, is something for everybody to take home, especially the practitioners. So if I think of what is evidence-based medicine, it is the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of the individual patient. So 3 components: best research evidence, clinical expertise and patient values. So you can see the yellow pie shows you the evidence base and what you've researched and what you've understood. Then you've used your clinical expertise to diagnose the patient. You've used your knowledge, skill, and attitudes to decide what the appropriate treatment would be. And then, of course, you need to apply it to the patient's circumstances, the preferences, his values, and his rights. So it's a big ask, and you're really asking doctors to be, superhumans if they have to exercise this entire evidence-based medicine thing. But it is something which we should strive for and yearn for. Thank you so much.
Thanks a lot, Shiva. And I think we can ask people to unmute themselves and ask any questions which they have. I think it's been an excellent discussion, and I'd like to thank all three of our panelists for sharing so much information with us.
I think there were one or two questions. There was Dr. Sachin Yadav has some questions. Dr. Yadav?
Yeah, I think that was answered. Use of remdesivir in stable CKD. What's the opinion?
So I think Bharat answered that. And what he said was that even though there is a recommendation against its use, we've been using lower doses in patients with chronic kidney disease. So sometimes, half the dose or alternate day. Any comments from the others?
Thank you, sir.
So certainly there's no issue whatsoever using down to an EGFR of 30. I personally use remdesivir only for 5 days. There is an ongoing clinical trial specifically for patients with more advanced CKD. It's the carrier cyclodextran that's the concern. If you have, for example, a patient receiving posaconazole or Vori with a cyclodextran carrier, you would still generally give that despite the cyclodextran. So I think the restrictions on remdesivir at lower creatinine clearance is probably unnecessary, although we do need that final data to come out. But again, I used it only for 5 days rather than 10, and I would use the same loading dose of 200 milligrams followed by 100 for 4 days. The other issue is, on the flip side, transaminitis. There's actually really good data, although we're fearful of transaminitis. Transaminitis is really a reflection of the viral disease here. And patients, if you give remdesivir to perfectly normal, perfectly healthy individuals, you can cause a transaminitis. However, COVID-19 that's hospitalized is associated with a general predisposition to significant transaminitis, not infrequently 5 times and above. If someone is eligible for remdesivir and I start them on it, I would not discontinue that patient from remdesivir personally outside of a clinical trial, even if their ALT, AST went above 5 times upper limit of normal, because in general, patients on remdesivir have lower levels of COVID-19 related transaminitis than patients with COVID-19 untreated with remdesivir. That the transaminitis itself is actually a reflection of efficacy with lower transaminitis on therapy, paradoxically.
Thank you. Dr. Baldev Singh has a comment. Baldev? Meanwhile, Dr. Baljit Sharma has a question. Dr. Sharma?
I think he answered it. He's showed in therapeutic trial masking.
So are there any other questions before we close? This has been a wonderful session. Thank you, Dr. Gottlieb. Thank you, Dr. Purandre. And thank you, Dr. Iyer. And thank you, Dr. Priscilla, for moderation, and for Dr. Baldev and Dr. Kinjalk for answering questions as well. We will meet again in 1 week. And Dr. Iyer, do you want to describe what you're planning to do?
So what I thought is we could look at the indications for invasive mechanical ventilation. Also look at whom you would triage not to receive invasive ventilation. Then look at the initial settings for a COVID-19 pneumonia, or as it is described as CARDS, COVID-19 associated ARDS. Then look at if patients are not responding and have refractory hypoxemia, then maybe look at a little bit about the prone use of prone position, and maybe a little bit about the use of ECMO. And then after we do that, look at after care of these patients, the post ICU or post prolonged mechanical ventilation syndrome that might occur. So that would be the approximate plan. And we'll discuss this as we go along in the week.
Thank you. Thank you all, and the best wishes to you as you go take care of your patients in our shared fight against COVID. All the very best. Thank you. Good day and good night.
Thanks.
Thank you. Thank you. Thank you.